So our next speaker is Dr. Kaleem Ullah Toori, whose extensive research and expertise in respiratory medicine have earned him international recognition. He currently leads pulmonology at KRL General Hospital, and today he will present his talk on characteristic of chronic cough in adults in Pakistani population, a cross-sectional study. So please.
Thank you very much. This is one of the most common referral into our chest clinic. So by definition, any cough which is there for about 8 weeks is a chronic cough. And about 10 to 20% of the population worldwide is having this problem. The commonest causes, which if we read the text, shows that the postnasal drip following viral upper respiratory tract infection, cough variant asthma, and gastroesophageal reflux. The other causes after these includes chronic sinusitis, chronic bronchitis, or smoker cough, and the medications, especially the ACE inhibitors. The less common includes the parenchymal lung diseases, cancers, and chronic infections. So this is the spectrum of the causes of the chronic cough which we find in the text. In patients with normal chest X-ray and with no history of smoking, the commonest causes includes these three groups: the upper airway syndrome, the cough variant asthma, and the gastroesophageal reflux disease. And the causes of the cough, they do differ depending upon the gender, age distribution, or BMI. I'm sorry for the busy and slide because I wanted to project this. This is the European Respiratory Society algorithm for the diagnosis and the management of the chronic cough. I just take you through this one by one. They say whenever a patient is referred to you, take a good history, do a physical examination, and they include chest X-ray and spirometry with reversibility for every patient which comes to us. These are the basic things which are needed for the diagnosis of the chronic cough in the very first stage. Now, if you read to a conclusion which leads to suspected asthma or upper airway syndrome, then you treat them accordingly, or if there is history of ACE inhibitors, you stop the ACE inhibitors and see the response. If the cough settles, it's okay, but if it doesn't settle, then you have to go further, and you will be asking for further tests according to the history which you have taken and which and to look for the causes accordingly. So the further investigations, they would be including the CT scan, the bronchoscopy, the esophageal manometry, or the gastroesophageal endoscopy. And then accordingly, you come to a conclusion and treat accordingly. If the cough settles, is fine, but if it doesn't settle, then it comes into the category of the idiopathic cough. And for these people, you go for a cognitive therapy or the trial of gabapentin and the other aspect. Now, this is the algorithm which was there in 2005. It was a bit simplified later on in 2015, but again, the gist of the algorithm remains the same. That is, you take a good history, and then you include the chest X-ray and the pulmonary function test. And they also suggested, if possible, the FeNO and the blood eosinophil count, they were added over here as well. Again, you come to a conclusion that it may be one of the commonest causes. You treat them accordingly. If they respond, then you keep them for the treatment for 3 months and then attempt to withdraw the treatment. But at any stage, if you think the patient is not responding, then you go ahead with the further investigation to look for the causes, like sputum for AFB if you suspect TB, high-resonance CT if you are suspecting ILD, or a CT scan with contrast if you're suspecting malignancy, and bronchoscopy, etc. So if you reach to diagnosis, fine, but if the patient has none of these, no problem found in these investigations even, and the cough persists, then again it comes in category of the idiopathic cough, and you go for the other measures like, again, I said, gabapentin, cognitive therapy, or some low-dose opiates. So this is the algorithm which is there in the text. Now, what we wanted to do, because we didn't have a data from our part of the world, that what are the commonest causes which we are seeing in here. So that pushed us to do a study to determine the causes of the common cough which are referred to us in our OPD. And then we also aim to determine if there's any correlation between age, gender, and weight to the causes of the cough. So it was a hospital-based cross-sectional study carried out in our Kerala Hospital, Islamabad. And during this period, we studied 236 patients. We took a detailed demographics and the history of these patients on a pre-designed performer. And all the investigations were carried out according to the routine procedure and the standard method of investigations in our hospital. The laboratory history included history of smoking, diurnal variational symptoms, reflux, the respiratory tract infection history, post-nasal drip, use of the medications, family history of asthma, and to look for the comorbidities. Every patient underwent chest X-ray and spirometry with reversibility performed in our department, and all the results were recorded. The X-ray were reported by the radiologist, and spirometry, which we interpreted ourselves in our chest department. Cough variant asthma, for just a bit of methodology, cough variant asthma was diagnosed with a combination of history and the spirometry results. For the post-nasal drip and allergic rhinitis, we did take an ENT evaluation. For patients whom we thought of ILD, they have an high-resolution CT reported by the radiologist. GERD, for GERD, we did take consultation of the gastroenterologist as well. For TB, they all have sputum cultures, sputum staining, gene expert staining and culture if possible. And for CA, lung carcinoma was diagnosed with the CT chest with contrast and biopsy. Similarly, some of the people did have features of heart failure, so we had an echocardiogram done and reported by the cardiologist, and accordingly, all the data was recorded. Now, we had 236 patients. The mean age of the cohort was 45, and the mean BMI was 26.3. Majority of the patients were female, that means there was 60%, so there was a ratio of 60 to 40. 60% of the patients were female and 40% were male, and 18% of the patients were smoker. So it's a chart which is showing the same, the mean age, the age-wise distribution. So majority of the patients were in the younger age or in the middle age. This is the gender distribution, and this is the BMI distribution. So the main causes of the cough which we identified, these were the four groups: the cough variant asthma, allergic rhinitis, GERD, and bronchial hyperreactivity. So these were the four major causes of the cough in this cohort, followed by ILD, then ACE inhibitor induced, and the others, which others included TB, malignancy, smokers, and heart failure. So about 70% of the causes included the cough variant asthma, allergic rhinitis, GERD, and bronchial hyperreactivity. Now, we then correlated these causes with the three which we aimed at in the beginning, with the gender, age, and BMI. So, in younger age group, the commonest causes were cough variant asthma and allergic rhinitis, and in the elderly, the causes included ILD, ACE inhibitor in root cough, and heart failure. So that implies that if a younger person comes to us in the clinic, the most common causes would be falling in this group, and if in the elderly, we should be vigilant to look for these causes. Now, in the gender, female had more ILD. So this is a thing which we have seen our registry in Pakistan from Karachi and my own group of the people, that ILD in our setting is more common in the females, that especially the IPF variety, as compared to the male. In the rest of the world, it's the other way around. So that this depicts the same as we have seen in our setting. And similarly, ACE inhibitor cough was also more in female as compared to the males. Smoker cough, as because prevalence of smoking is more in male in our setup, so smoker cough was more common in the male population. With the BMI, we couldn't find much relation, apart from the fact that the ACE inhibitor was more in people who were obese. So, in nutshell, the younger people would have these causes, the elderly would have these, and if we do the gender discrimination, then more ILD in female as compared to the others. So, in conclusion, we had the commonest causes of the cough were in asthma, bronchial, the postnasal drip, and the esophageal reflux as the main causes of the chronic cough in our setting. And now, this is vital for us to have this thing in mind, because these people are visiting physician to physician and to physician with the same complaints. So we should have an algorithm, or we should have a scheme in our mind that whenever we see these patients, we should be vigilant that if this younger patient come to us, the more common causes would be this, and if an elderly coming to us, then we may have the other causes, and we should keep our mind open so as to quickly diagnose and to manage these patients. So, thank you very much.